Good afternoon. I'm Bob Blum, and I'm the head of the Urban Health Institute, and it is a pleasure for me to welcome you and to welcome Ms. Washington to this, our first Race and Research Symposium. Let me tell you a little bit about the series that we're launching today, what we hope to accomplish by it, and then I will introduce our first speaker and tell you how the session will run. The primary intent of this series, and the second one I would mention, is on April 1st, Dr. Gail Wyatt from UCLA will be spending the day with us. The purpose of this series is to begin to engage the Johns Hopkins research community and our neighbors who live across the street and across town in conversations about research and about race that perhaps we haven't had before. The intent of these conversations is to understand better what it is about research, not just research that we do at Hopkins, but research in general, that so many of our neighbors, and particularly in the African American community, find threatening and problematic, and more importantly, what it is that we can do to move beyond the history. I believe firmly, as John Dos Passos said, that if you do not know history, you will be condemned to repeat it. So part of today's intent is to know the history better from where we came so we can move beyond it. If today is a brilliant lecture and nothing happens, I will consider it a failure. If today engages those of us who are sitting in the audience in ongoing discussions, then I will consider it an extraordinary success. The issues we'll be talking about are complex. There are many divergent opinions around many of the issues that confront biomedical research and race relationships in the United States. But unless and until we have frank conversations with our neighbors, I don't think we will move beyond where we are today. I think that Harriet Washington is about as well positioned as anyone in America to initiate this dialogue. Ms. Washington is a journalist and a bioethicist, is a senior researcher at Tuskegee University, the National Center of Bioethics, and a fellow at the Harvard School of Public Health. She has written on a number of medically related issues, including living with hepatitis C. But the most powerful volume that I have had the opportunity to encounter is Medical Apartheid. And in that volume, Ms. Washington traces the history of research on Black America. She comes at it with the lens of a journalist who brings together a lot of information and synthesizes it, and has perspectives, I think, that will be extremely important and no doubt provocative. The way that we will run the session is that Ms. Washington will lead off with the presentation, and we will follow that with a panel. We have an extraordinary group of panelists, a truly extraordinary group of panelists, and I will introduce them after Ms. Washington's presentation. They will each be asked to make a few minutes, 3 to 5 minutes, to be exact, how few, a few minutes of comments. During that time, we have handed out index cards. If you have questions that you would like to pose, please write your question down. It will be the best and most efficient way of getting as many questions on the table. And we will then form a panel, including Ms. Washington, and have a dialogue among the group on the questions and issues that you have. So without further ado or introduction, Harriet Washington, thank you very much for joining us.
Thank you, Dr. Bloom, for that very generous introduction. And thanks to all of you for coming out this afternoon. I'm tremendously excited to be speaking with you. Every time I talk, there's some new gadget I have to master. Give me a second. I'm going to be talking about the history of medical experimentation with blacks and focusing on the most troubled aspects of that history. However, since there's no possibility of my condensing my 500-page book in the 30 or 40 minutes that I have, please don't be surprised. I'll be skipping over some of these slides. I'm going to focus today on the subtitle of my talk, Race, Fact, and Myth in U.S. Medical Research. One of the things that constantly surprised me as I did my research was how much myth was masquerading as fact and vice versa. A lot of surprising facts, a lot of mythology on both sides, and I'm convinced that plumbing it and examining it a bit can help us a great deal in our quest for equity in medical research. But I want to start off with this discussion of American problem with something that transpired in Nuremberg, Germany over 50 years ago. It was a U.S. Chief Prosecutor, Robert Jackson, and other U.S. lawyers and prosecutors and physicians who challenged Nazi physicians over their cruel and genocidal abuse of Jews and other Eastern Europeans during the World War. And Prosecutor Jackson said, "The wrongs which we seek to condemn and punish have been so calculated, so malignant, and so devastating. The civilization cannot tolerate their being ignored because it cannot survive their being repeated." And without being unduly melodramatic, I do want to suggest that we're at a crossroads today. We simply can't afford an extension of our history of medical research abuses, and we certainly cannot afford their fallout in the form of wariness and fear and iatrophobia among Black Americans. I'm going to skip the definition of an experiment. I'm sure that you're all very familiar with it, but I did want to just take one moment to talk about the import of history. A lot of the history that I'm going to line very briefly for you today has been overlooked. It hasn't been unrecorded because I'm not a trained historian, and frankly, I found a lot of it quite easily. But it's something that has not been focused upon. And that means that there are a lot of facts without which we have been operating. Not having these facts has been very hazardous for our quest for including everybody in equitable medical research. I might even suggest that it's like trying to treat a patient without eliciting a thorough medical history. We've been trying to address our medical research problems without looking at the history of that research. And I'm definitely not reading this slide to you. It's simply a list of the chapters in my book. The point is that the Tuskegee syphilis experiment, as it's popularly called, an experiment that was designed and carried out by the U.S. Public Health Service, has had far-reaching effects, but it's also become an overburdened icon. Tuskegee has become synonymous for a medical abuse of African Americans, and yet it shouldn't be. It shouldn't be because all the many chapters I've lined here are only some of the species of medical research abuse that I unearthed during my research. Everything from the abuse of captive African Americans on the plantation and in early clinics, to the display of their bodies against their will, and their preferential display and use in anatomy laboratories, right through the reification of black inferiority through medical research that we saw in many, many arenas, but I would say most dramatically right in the postbellum era, where, the antebellum era, where we instituted research protocols to demonstrate that black people were both so frail and so unintelligent that they could not survive without slavery, and that slavery was necessary to perpetuate the existence of black people. This was canonized in US medical research papers. So then, of course, we had the Tuskegee experiment, eugenics experiments in the chapter that I called the Black Stork, research with radiation, non-therapeutic radiation experiments, prisoners, children, genetic research, and also research with infectious diseases, as well as using black people disproportionately to perfect surgical technologies, which they would never be able to afford. So the whole canon of this history, though, as I said, has been overlooked. And now, even when sophisticated researchers often want to pinpoint a reason for black people's aversion to the medical research arena, Tuskegee is summoned up. So, the discussions of trust that are going to have to predicate this have been ignoring not only medical history, but medical mythology. Very often when we talk about myths, we find that we find ourselves talking about the myths perpetuated by the other, the myths of people in underserved communities, the myths of African Americans, but we can't forget that medical institutions and medical researchers and medical practitioners have their own mythology like every culture does. And this mythology has worked against the welfare and worked against the image of African Americans in ways that I'm going to discuss briefly. Also, we have to remember that the word myth is a very powerful word. In one sense, in one semantic sense, a myth is neither true nor false, something that scholars invoke to talk about cultural beliefs, beliefs that telegraph not only the culture and morality of a people, but also its most deeply held beliefs. But often when we talk about the myths of African Americans, the myths, for example, around the Tuskegee experiment, it's done in a dismissive way, to dismiss it as not only being untrue, but born of credulity, born of people who have, let's just say, who are not very discerning, not terribly intelligent, not terribly compliant. So it can be quite insulting when we evoke myths. We really have to be careful when we use this language and realize that in different semantic contexts, it can indeed be very off-putting. So essentially, we're at a crossroads now where a lot of the history, the vast majority of the history that I'm going to line for you briefly has expired, and now medical researchers want African Americans to trust them. Trust is very important. In fact, it's essential for good medical care for reasons that you're all probably very familiar with. It lies at the heart of the patient-physician dyad, that caring, healing relationship. It's based on the trust of the patient. But historically, African Americans have been deprived of some components of trust. And so, for example, there has not been a patient-physician dyad during a large part of African American history. Instead, at the beginning, there was a physician-planter dyad between physicians and the planters who employed them, the planters who they had to content with their work, who could hire them, pay them, and the patient, the slave, was actually left outside, unconsulted, and without recourse if he were harmed or dissatisfied or killed. African Americans also have lacked a history of body ownership. I don't mean literal ownership, because the law is very interestingly schizophrenic in terms of assigning us ownership of our own bodies. But insofar as it does, African Americans have a long history of having the ownership and control of their bodies being ceded to other people. It's given to planters, slave owners, the state, the prisons. And so without this history of body ownership and without this history of a healthy, positive patient-physician relationship, trust becomes a very chimerical, a very, very volatile commodity, something that's not easily come by. Very briefly, this is a pantheon of medical heroes. And this is one of the medical myths that is cherished most by the medical profession. Who our heroes are. In the United States, here are a few of the people who have been adjudged our heroes. They made wonderful inventions. They designed procedures that saved many lives. They developed medications that saved people from the scourge of many illnesses. There's no question that they did great things, beneficent things. But are they really heroes? They are heroes in the eyes of most people, but most of them are not heroes in the eyes of African Americans because each one of these people has participated, if not devised, the savage abuse of African Americans. The man in the center, James Marion Sims, was a man who cured vesicovaginal fistula, but he did it by using only black women, captive black women, whom he kept in the laboratory and experimented on repeatedly without anesthesia. Taliaferro Clark on the left, John Heller, Raymond Vondelier, and Thomas Perrin, who is Surgeon General. Well, Perrin is considered a hero because he vowed to eradicate syphilis, and on his watch as Surgeon General, that indeed happened. On his watch as Surgeon General, penicillin was found to cure syphilis, but when Perrin was asked, now that we can cure syphilis, shouldn't we give this drug to these black men in the Tuskegee study, these hundreds of men who are suffering from syphilis? And Perrin said no, because the opportunity represented by these men will never come again, and we have to fully exploit it. So on and on again, we find that these men who we call medical heroes are not medical heroes from an African American perspective. And so in that sense, their heroism is mythological. Here's a statue dedicated to James Marion Sims. It's in New York City, Central Park, right across from the Academy of Medicine. I sat under it many days eating my lunch as I researched this book. And I remember I once had warm feelings for Dr. Sims because I had read about how he was the first archetype of a women's doctor. It was a few years before the term gynecology came into use. But he was a woman's doctor, devoted himself to the cures of women, and I felt very warmly about him until I found out which women he used. So as I pose in my book, the question becomes, was he a savior or a sadist? And the answer is, it depends on the color of the woman that you ask. Another illustration of Dr. Sims. And in terms of perpetuating mythology, I just wanted to use it as an illustration of how art will do this. If you look at this image, you find a woman who's kneeling on a table with a sheet hung behind her, obviously for the sake of modesty. It was a Victorian era, after all. Her hand is raised, modestly to her breast, and the doctors stand around, and behind her, to the left, two slave women look at her behind the curtain, peeking behind the curtain, in an almost childlike display of curiosity. It's a very benign image in cartoonish colors. It's just very fitting with Robert Hahn's whole canon of art that he performed in the service of medical heroism. But it's a lie. In reality, each woman that Sims operated on was not kneeling with her hand raised to her breast in front of a curtain. She was naked. And the other two doctors were not there to assist in the surgeries. Their job was to hold the women down, which they had to do because there was no anesthesia used, and the women were screaming and fighting the surgeons the entire time. The use of black women to perfect reproductive technologies and surgeries in the early years of our country was actually typical. Here's a list of procedures and men who used only black women and enslaved women for their procedures. I've also listed some experiments done during that time to show you there's a wide range of experimental procedures, and they were also, many of them, quite crude. For example, Walter Jones was treating slaves for typhoid, and he had the bright idea of throwing boiling water on them. He made them strip naked, lie on the floor, and he threw boiling water on them. And his rationale was that he felt that this would somehow, in his words, reestablish the capillary circulation. I don't have an MD, so I don't know exactly what he meant by that. But I suspect that those of you with MDs will be equally mystified. A Dr. McLeod wrote his master's thesis on malingering among slaves. He codified into research the prevalent belief that slaves and black people in general were liars, so that when you had a patient who was black, you had to assume that he was lying or malingering. So there were a variety of these kind of surgeries done, and these techniques were all very crude, and they were all clearly directed at black people, in part because black people, 90% of whom lived in the South and were enslaved during the early years of our country, had no legal standing. A white person might complain or go to the authorities. A black person had no standing. But there was more to it than that. It wasn't just a belief. It wasn't just convenience. There was also a belief in the inferiority of black people. And that's where the American School of Ethnology comes in. These were the specialists, the experts in the Negro. And they quibbled about some points. For example, some of them believed that blacks and whites shared the same species. Others believed that blacks were members of a different species. But they were united in their belief in black inferiority. Those who thought that blacks shared a species with whites thought that blacks were still profoundly degraded, would never catch up to whites. Samuel Cartwright was one of the more interesting of these scientists. He was a physician, and he defined a number of black diseases. It's important to remember that we may sneer at these findings as pseudoscience now, but during their time, this was simply science, and it was promulgated by the best minds of the time. So Cartwright said that black people suffered from diseases nobody else suffered from, due to their profoundly inferior minds and bodies. He said that black people suffered from drapetomania. That was a disease evinced by a slave who ran away. Struma africana, Dysesia ethiopica, Hebitude. These were diseases characterized by talking back to whites, breaking the property of your master. In some cases, they were just black variants of diseases like tuberculosis. Hebitude was simply laziness, refusal to work. And you might see a pattern developing here. These diseases have something very important in common, and that is a lack of enthusiasm for slavery. During this time, people who had symptoms of these diseases and were black were assigned a psychiatric diagnosis. And then Josiah Knott, another physician, and his partner, George Glidden, went on to make very detailed designations of who belonged to what race. Now, along with the imaginary diseases suffered by black people, there was also a belief in imaginary immunities, diseases that black people did not get, or at least if they got them, did not die from. And there was a rousing debate over syphilis. You know, the debate was, did black people bring syphilis to this country, or did we bring syphilis to them? And this illustration, which I at first glance, when I saw it, I didn't think much of. I thought it's just a depiction of an assault. But then I realized, if you look at the face of the sailor is cadaverous. It's the way that 17th, 18th century people depicted people with syphilis. And I realized it was an artistic rendering of the author's belief that syphilis was something transmitted by Europeans to blacks. Among the diseases that black people did not die from or did not contract were malaria, yellow fever, heat illness or heat stroke, anxiety, heart disease, exhaustion, etc., etc. So blacks and whites were felt to be so profoundly different, so biologically dimorphic, that they actually succumbed to different diseases, which meant they had to be treated by different medications. The other really dramatic belief about black people and scientific racism, as this nucleus of belief is called, was that black people did not feel pain. This became a really important belief during the antebellum era. And of course, black people were thought to be unintelligent. They were also thought to have a very unrestrained sexuality that was often compared to rutting beasts. So as you can see, that early in our country's history, black people were treated very badly by the medical profession, not just physically, but also in terms of liming their character. And they were considered evolutionary laggards. You know, perhaps they were human beings, perhaps. But if so, they were so far behind whites that they could never catch up. Now, if we think about our mythologies, it's very difficult to see our own mythologies. It's almost laughable to think that in the 19th century, doctors believed that black people did not suffer pain, and they could make statements such as that made by Dr. Charles White, that he had amputated the legs of many black people who had held the upper part of the limb themselves. Or by Dr. James Johnson of London, who said that, yes, they did all these reproductive surgeries on women in Kentucky, but they were all black. So the fact that they did these and they were so painful and the women survived, that doesn't really mean anything. You know, they were black people. So they were very dismissive of pain among black people. And that seems, sad and even laughable to us today, but if you look at our concomitant behaviors today, you can see the evidence of a troubling hangover. I mean, even today we find that black people are much less likely to have their pain acknowledged when it occurs in settings where there aren't discrete tests for it. For example, studies done of broken legs have found disparities in the use of analgesic medications, and there are often studies done of sickle cell disease. In London, they looked at adolescents with sickle cell disease, and they found that adolescents who were treated in the emergency department of the hospital where they were getting their sickle cell treatment could not get effective analgesia. They would go to the emergency department and they would not be given the Demerol or the strong analgesic they were used to getting because the staff would consider that they were probably drug seeking. Yet in these hospitals, their medical records were available to staff, but that didn't sway the behavior. In this country, as the last bulleted item shows, if you go to black and Hispanic neighborhoods, you're less likely to be able to get a prescription for a strong analgesic, even if you have, to get the analgesic even if you have a prescription. And when pharmacists were asked about that, they explained that, well, we're in a black neighborhood, it's it's full of drug-seeking people, we can't stock these medications. So when they were asked, what do you do if somebody comes in whom you're convinced has a valid script, the response was, we can get any drug we want in 72 hours. An eternity for someone who's in that kind of pain, as you know. So the early clinic also was rather unabashed in its characterization of treatment by race. Not only were there separate clinics held for blacks in which people were treated free or at reduced rates, but only in exchange for submitting to medical research, there was also the opinions of teachers, like Dr. W.H. Robert of Georgia, who said that you have to stratify whether or not you do an amputation. If he's a white person of property, that should be your last resort. But if it's a black slave, it really doesn't matter. It's a matter of little import. Then there was a medicalized display of black bodies, which took place in circuses in a propagandistic environment. Essentially, the message was that Africans and black Americans were the same peoples and that they were all profoundly degraded. They were often displayed in cages with feathers, or they were told not to talk. There was a case in Syracuse where a man named Calvin Bird came to a clinic and asked to have his implanted horns removed. He had had horns implanted in his head by his owner, who was displaying him as a typical subhuman denizen of an African country. We even had an example of that in 20th century New York City, where a slave named Ota Benga was held for 2 weeks in a cage with an orangutan as his cage mate. We have Cesare Lombroso, who was an expert on violence, who had espoused this theory of criminal man. And when he wanted to take his exemplar of people who were born criminal, who could not be changed by medical treatment, by psychological treatment, by therapy, by education, they were simply going to be violent, no one could do anything about them. And his exemplar were the Dinka of Africa. And finally, we have anatomical dissection. Because during the Victorian era, the dead body was considered sacrosanct, nobody was willing to become a subject for anatomical dissection. But time after time, we find in the recordings of the resurrection men, whose job it was to get bodies, and in young white professors of anatomy, that reassurances that the provenance of their dead bodies was a local black graveyard. In fact, we had a really dramatic example of this in 1995 when the Medical College of Georgia at Augusta was being excavated, and construction workers found 9,800 bones in the basement. And 75% of these bones were later found to have come from the local black graveyard. Black people in the area had been complaining for centuries of the physicians and residents raiding their graveyard for bodies. In Baltimore, which has an especially rich medical history, both good and bad, Harriet Martineau, when she traveled the colonies, actually it was the United States by then, wrote, in Baltimore, the bodies of colored people exclusively are taken for dissection because the whites do not like it and the colored people cannot resist. I'm happy to say that Martineau was speaking not of Johns Hopkins, because Johns Hopkins, as I note in my book, was the only hospital in the state that followed the law and only took the bodies of people who had volunteered their bodies. All the other hospitals and medical schools in the state had their bodies provided by entrepreneurs who would go and dig up bodies in the dead of night after people had been buried. There was also a really interesting prevalent myth. I use the term myth advisedly. I'm not implying that it's true or not, but it's very fastly held by many African Americans. In fact, I will speak all over the country, and people often ask me about this myth in regard to Baltimore specifically. They will say, we've heard that you couldn't walk around the streets of Johns Hopkins at night because doctors would snatch you if you were black and use your body for dissection. Now, usually this is dismissed as an outright myth. However, in the sense that, of course, it can't be true. However, in 1886, there was a documented burking, which is a murder effectuated for the sale of the body to anatomists. It was done of Emily Brown. She was a white woman, but she had a black boyfriend, and she lived in a black neighborhood. And this is the one fully documented case of this having happened. Now, there are no documented cases of any black people, or anybody else for that matter, having been burnt in Baltimore. But I suggest that this might just reflect the social mores of the time. There weren't any cases of black women being raped by white men at that time either. It doesn't mean it didn't happen. So we don't know whether it happened, how often it happened or not. But you see the difficulty in simply dismissing it as patently untrue. We don't know whether that happened or not. There were other cases, such as one that's been immortalized in Lawrence Altman's book, Who Goes First, of a black man who was seized by medical students and made to inhale ether and then left for dead in the road. So, and that was actually repeated in the history of an anesthesia textbook from the 1900s. So there are cases of black people's bodies being taken for medical use. And so I think we need to keep that in mind when we hear this and realize that although it may or may not have been true, it may or may not have happened in any numbers, a myth is one thing, paranoia is another. This is not paranoia, because paranoia is a baseless fear. And this fear actually has some basis in fact, whether it's true or not. Now, also in Baltimore, we had a lot happier news. One of the things I mentioned to Dr. Bloom was how dramatically how overrepresented black medical researchers are at Johns Hopkins. There's quite a wealth of them. I'm doing an article about the history of black medical research, and so many of the black researchers who have generated really impressive developments or devices have actually done so at Hopkins or while being trained at Hopkins. It's really quite impressive, and I wish this were a history that were better known. There's another history that is not very well known, and it's actually a lot less positive, and that's of the 1951 death of Henrietta Lacks. This was a woman, lived in Baltimore, who became the source of the first, she's called immortal, which is a little more than I know, but the first very long-lived human cell line. The cells were taken from her body against the wishes of her husband, who had refused permission, and they've been kept alive in petri dishes and test tubes ever since. I spoke with Victor McCusick, who told me that in the aggregate, Henrietta Lacks cells have been invaluable to medicine. There's no assigning a monetary value to them. They've been very, very valuable, and yet her own family was not told that her cells were being used in this way, and they were repeatedly deceived by researchers who came and took samples from the family and lied to them, saying they wanted to check them, make sure they didn't have the same disease their mother had, when in reality they were just trying to use this as a reference to check the spread of her mother's cells. So there have been a number of very troubled research abuses between African Americans out of Baltimore and some out of Johns Hopkins that are very troubling. It's really important, in my opinion, to have transparency, to acknowledge this history. We can't hope to go beyond it unless it's acknowledged, because you can't hope to gain the trust of the populations who have been affected directly or indirectly unless you first acknowledge what's happened. And what's the legacy of this research? Well, I think we all know a lot of it, but greater wariness to research, which is often, as I said, ascribed to Tuskegee experiment, but without proof. I'm convinced that it's not the Tuskegee experiment because before there was so much publicity about it in the last 10 years, I would speak to people who had never heard of Tuskegee and yet did not trust medical researchers or even physicians. I think it's really important to acknowledge that, again, it's not paranoia, but a fear of medicine or a iatrophobia that we're dealing with here. Calling it paranoia is a dangerous misunderstanding. You can't simply assume that a lot of these beliefs are patently false. Some of them have been shown to be true or have some roots in reality. And there's a greater wariness on the part of blacks in medical research than whites, although whites' wariness to medical research is not exactly improving either by some measures. And although these practices have diminished greatly, but there are still dangers, abuses remain, and African Americans, in my opinion, still need to be wary of medical research, although we need both more wariness and more research. I'm going to skip some of these ethical considerations because I want to talk a bit about some of the mythology around what's called the Tuskegee syphilis study. Some people are trying to change its number to the United States Public Health Service study of syphilis. Good luck, it's kind of unwieldy. But it's more accurate. It's more accurate because it was not a study of Tuskegee University. It was a study of the United States Public Health Service. And just to recap what many of you will already know, essentially, researchers from the Public Health Service lied to people in the Macon County area. They put out flyers promising treatment for bad blood. And when people came, those who tested positive for syphilis were told that they would get a great deal of treatment for their bad blood. Instead, they got no treatment for their bad blood or syphilis, and instead they were monitored over a period of 40 years. They were monitored closely. Their health status was evaluated in order to trace the ravages of the disease, and then, when they died, the Public Health Service wanted to conduct autopsies in order to trace the ravages of the disease. Now, in my book, I describe some new information about the study. For example, I talked for the first time, nobody had ever done it before, to the people on the ad hoc panel who stopped the study and found some rather shocking things. But nothing shocked me as much as finding that the rationale for the study, which is rarely distressed, harkens directly back to the 19th century American School of Ethnology beliefs. These Public Health Service physicians believed, in the 20th century, that syphilis in black people was different from syphilis in white people. That in white people, syphilis would attack the brain and nervous system, causing paresis, devastating neurological ravages. But that black people were spared this. Black people did not get paresis. Black people did not suffer any kind of psychological or neurological problem because black people had a very primitive neurological system, a primitive brain that could not be deranged by syphilis. That was their belief, and they sought to prove that black people suffered only heart problems and only muscle problems as a result of syphilis. That was the point of the 40 years of monitoring and also the point of the autopsies they conducted. They actually wrote a paper stating this, but a blue ribbon panel of cardiologists looked at the paper and said, that's nonsense, you haven't demonstrated anything of the kind. So, in the wake of the study, a lot of myths sprung up. And the first one was that the Public Health Service had injected the men with syphilis. I don't think this is the case because, frankly, the notes of these researchers were so frank about everything else, I don't believe they would have shrunk from saying so had they done it. You have to look at this in context. It was not an unusual thing for researchers to inject Americans with venereal disease or infectious disease. In fact, historian Susan Lederer of Yale tells us that American researchers did this on at least 40 occasions during the 20th century. In 1926, Dr. J.A. McIntosh wrote quite proudly of having effected the first successful experimental transmission of granuloma inguinal into a black American. This is not something that they would have hidden or been embarrassed about. So Where did the myth come from? There's always the assumption that this must emanated from overheated African American imaginations. But I talked to researcher Jay Katz, whom we lost recently, unfortunately, and it was Jay Katz who first pointed out to me that this myth came from the congressional record. It was the researchers themselves who first said that they had injected the men with syphilis. Another really prevalent myth is that the victims of the study were Tuskegee Airmen. Now, at first blush, you can easily explain this away as just a mistaken identification. Tuskegee Airmen, Tuskegee syphilis. And it wasn't really helped by the fact that the HBO specials on the subject, Tuskegee Airmen and syphilis, both starred Lawrence Fishburne. So I think that could be confusing to a lot of people. But I believe that there's more to this. I believe that this prevalence of this myth, it's so tenacious, reflects an unconscious, perhaps, acknowledgement that Tuskegee University was also a victim of the study. Tuskegee University was the black Harvard. Black people came there from, and whites as well, from all over the world. It had very high standards. It did a great deal of scientific research. In fact, when the HeLa cells I spoke of were first used in production of polio vaccine, it was done at Tuskegee Institute. Tuskegee Institute turned out hundreds of vials every week. It was considered a mecca for black people who were interested in medical research, scientific research, physical research. And now, if you say Tuskegee, people think of one thing: an abusive study. So I believe that the tension of this myth has to do with this feeling of this sadness, this despair over the fact that our Harvard has been irreparably besmirched. There's also something else that I believe is mythical in nature, and it's uncomfortable, but we have to address it: black complicity. Very often people speak as if it's taken as a matter of course that if you don't want black people to be abused in medical research, or if you want them to feel more comfortable with it, then we need more black medical researchers. And they're right. We do need more black medical researchers. Medical research should be more representative. The more representative it is of our astonishing diversity, the better a job it's going to do. But being black is no guarantee that you're not going to participate in harms done to black people. And we have seen over and over again that some black people have been willing to do this. But what I found interesting as I researched it was that very rarely were they physicians. Many black people were taken untrained and elevated to positions where they were asked to abuse African Americans and did so. But I only found one black physician that fit that description. Now, Eunice Rivers, who was a nurse in Tuskegee's study, in my opinion, has gotten a bad rap. The entire weight of the study is hung on her shoulders, and yet she was a poor public health nurse in Alabama. How much power could she have had? Yeah, I do wish. I can't totally exonerate her. Her crime, I believe, or her flaw, was that she believed in the researchers who told her that they were helping people. So whether she meant to or not, I'm sure she didn't mean to, because all her spontaneous speech and writings focused on taking care of people. But she was used to harm these men. There's no getting around that. And then we have other examples. Dr. Kligman at Holmesburg Prison, decades of abuse on mostly black inmates. His second in command was a man named Solomon McBride, who had no training whatsoever. No training at all, not as a nurse, not as a clinician, not as a pharmacist, and yet he was the #2 man in the program. He was a deputy. He oversaw the day-to-day running of that program. And that was very abusive of black people, and when I spoke with him about his role, his responses were very unconvincing to me. At the same time, there were also troubling assumptions. If you look at the photo on the right, you see Eunice Rivers is on the left. Some other physicians involved in Tuskegee study are there, and then there's another black man wearing glasses, second to the right, top row. The captions on this photo, when it's reproduced, usually indicate these were people who were the architects of the Tuskegee syphilis study. Yet this man had nothing whatsoever to do with the study. He just had the bad luck to be in this photograph when it was being taken. So, bottom line is, black complicity existed. There were some black people willing to participate in the medical research abuse of blacks, but there were rarely black physicians, and my opinion, and it's only this, is that because Part of it had to do with the fact that for a very long time it was very difficult for black physicians to gain entrance into the research mainstream. One of the interesting patterns I saw was that there was a real fraud, and the research of African Americans have tended to be traveling partners. Many of the researchers who engaged in abuse of African Americans also engaged in fraudulent research. In my book, I talk about Dr. Hamilton of Georgia, who used his slave, or used his friend's slave fed, to devise some sunstroke pills. And he did a great deal of research, abusive toward fed, but he did a lot of work in the research, but then in the end, he decided to bypass the research and simply make flour and water pills and market them as sunstroke pills. The IQ tests were based on fallacious and specious research, clearly specious research. And in 21st century, the Witzer-Wan researcher in Africa did breast cancer research in which he used total body irradiation on women and claimed that it worked just as well as the regimen that was a standard of care. It didn't. He had falsified books claiming that, and he had used black women to experiment on black women who he had never told were involved in research studies. Instead of saying anything about the long and very painstaking history of specious research used to prove that blacks were lower intelligence, then I'm going to refer you to this excellent book. Those of you who haven't read it are going to find it in Revelation. Another really good book on the subject is entitled Even the Rat Was White by Robert V. Guthrie. Very witty history of psychological research. One of the other medical myths that we have to deal with is forbidden knowledge. Some things were simply not disseminated. For example, the non-racial character of some diseases, pellagra, syphilis, cholera at some time, they were at some point shown to be diseases that didn't just affect blacks, but that information was never disseminated, and clinicians never always behaved as if only blacks got the disease. So the research had been done by Goldberg in the case of pellagra in the 1920s, but it was ignored for at least 20 years. Then the myths of scientific racism, the census of 1840 was used to prove that blacks needed slavery to survive, and it was refuted almost immediately by James McCune Smith and by Jervis out of Boston, but the rebuttal was ignored. So that's another issue that we have, ignoring some avenues of medical research. And none, I think, is more devastating in one sense in terms of African American trust as ignoring black medical researchers. I think that if we gave more currency to what we know of the innovations by black medical researchers, that black people would have a different view of medical research. They would understand it's something they could participate in. And I won't go through all their names, but here are a few. As you can see, Hopkins is overrepresented here. We've got Levi Watkins, Solomon Carson. So the question becomes, where are we now? And we're at a better place now because the frankly abusive research of yesterday is mostly gone. It doesn't happen now. We don't have any more Tuskegees. We don't have any more thefts of bodies for anatomy laboratories. We don't have any more clinic patients having their legs amputated just to demonstrate to medical students how the procedure is done. That's good. That's very positive. But we do have new problems, more subtle, but just as real. And ironically, one of them is the fact that African Americans are often excluded from research, sometimes because of their own fears. This is true. But sometimes they're excluded from research, well, for a variety of reasons, but these reasons are mediated by the researchers themselves. Either it's deemed too difficult to involve them, or for some other reason, when black people are underrepresented in medical research, the result is sometimes cures or at least treatments that don't work well for blacks. A really good example is hepatitis C. Interferon B wasn't found to work poorly for black people until it was already on the market. And there were so few blacks involved in the initial research that perhaps we really shouldn't have been surprised. There's also the erosion of informed consent, which I consider one of the largest threats, both ethically and practically, to medical research with African Americans. It really threatens all of us. The exceptions to informed consent in the Code of Federal Regulations are being exploited more and more frequently. Some researchers will call it rare, but I submit it's not rare anymore. The polyheme experiments where a blood substitute was given to people without asking their permission, forget informed consent, they weren't even told that they were being given it. Well, having given this to 730 people in this country, at 32 centers around the country, and the results so far have been disastrous. Higher rate of death, higher rate of heart attacks. Instead of establishing a moratorium on research with people who are not consenting, our government instead decided to expand it. Now we have something called the Research Outcomes Consortium, where we've got a goal of 20,000 people to be used in 15 studies, none of whom will be given the benefit of informed consent. I think this is going backward, and it's a big problem if you're asking for disadvantaged people to participate in medical research, for them to know that there's a possibility of their being conscripted into that research. So I think it's something we need to roll back. But it's vitally important for African Americans to engage in medical research, not just for the reason I mentioned earlier, which is that without it, we're going to be left out of cures. It's also very important because being left out of cures and also not having our own self-designated issues addressed. The way medical research is conducted now, the medical researchers don't just answer questions about medicine, they also get to ask those questions. If African Americans were more involved in the medical research process, they would have a voice in identifying issues and problems. And although they're not trained as medical people, they do have an intimate knowledge of what their community's issues are. And this would only enrich medicine. But it's not going to happen unless they feel secure, unless they feel as if they can trust the researchers and they're not going to be abused. I'm not going to go into a lot of detail about language, although I love to talk about language, but we have some jargon issues. We were talking earlier today about informed consent forms and how important it was to make these legible to everyday people. But we also have to abandon some of our semantic acrobatics. We're not going to have what we think of as classical informed consent in research. We have to stop coming up with these oxymorons: presumed consent, deferred consent, waived consent. They're all united by a lack of consent. And it's really important, if you want to be seen as someone who is truthful and trustworthy, to be truthful and trustworthy and to avoid these kind of semantic acrobats. I think that as a whole, that really goes to the heart of what I have to say here today. And if you don't take anything else away, I think the really important thing to remember that it's not just the mythology of subjects, but also the mythology of people in medicine that we're up against. And it's just very important to understand that it's not just distrust on the part of the subject, but also the trustworthiness of the system. We have to make sure that the medical research system is trustworthy before we ask people to invest in it. And in the realm of solutions, I'll be very succinct because I see I'm running out of time. And I would say number one on our agenda should be banning exceptions to informed consent in medical research. Again, I feel that we're finally moving in the right direction in terms of inclusiveness and communication with African American communities, and to ban and to get rid of informed consent or to weaken it in any way is going to take us in the wrong direction. I also believe that in IRBs, the community representation needs to be expanded. Personally, I think a 50% mix would be best. And I also think there should be a nationwide mandatory system of education, and it should be federally funded. Education so that when people learn about medical research, they're not learning about their options and their responsibilities and their vulnerabilities and their benefits for the first time from someone who is actually administering that research. They'll learn it from a disinterested party. And they also will have some tools, such as what questions should I ask? That's something that every subject should know. What questions should I ask? How can I evaluate a study? They will have this before they come to you. And I think it will enhance your efforts to do informed consent, and it'll also enhance their confidence in the system. They're going to feel that they have some way of navigating it, and that they won't be totally at the mercy of whoever study they're enrolling in. I also think that we have to restore non-commercial research funding to the FDA. Too much of the money that is spent on testing new drugs and products comes from the makers of those drugs and products, a very clear conflict of interest that we've got to get rid of. And I also think that these companies whose pharmaceuticals and devices are being tested by the FDA should be forced to disclose all data to the FDA. That doesn't appear to be closely allied to research trust issues, but believe me, it is, because when they're able to shield the results of these trials, then you're leaving it not in the realm of data and facts, it goes into the realm of myth. That's something that's already happened with polyheme. Frankly, the data does not look that good, but trust me, the myths are even worse. And finally, anything that we can do to increase the affected persons, that is what we tend to call the community, input into the conduct of their local research trials is positive. Anything that we can do. Those people who are very successful in recruiting people from other communities always say that they are successful because they have made it very clear that they're there for the long haul. They have established themselves as part of that community, and they communicate with them and educate them and spend time with them even when they're not seeking to enroll someone for a trial. And that they believe that makes all the difference. So thank you so much for listening to me this afternoon. It's been quite a pleasure to speak with you.
Thank you very much. An extraordinary review of medical research. I'd like to ask the panelists to come up. I will introduce them as they do. And I am particularly sensitive to the fact that Dr. Poe will need to leave in the very near future because he's headed down to Washington. Neil, I think I'll introduce you first and ask for you to make your comments. In the meantime, because not everyone heard it, if you have questions, jot them down on the cards we handed out or on a piece of paper. Pass them to the aisles, and there are people who will be picking them up. Just hold them up, and we will take those cards and incorporate them. There are mics on either side, but I think it'll be much more efficient if we're able to do that. So I'll introduce Professor Poe first, ask for him to make comments, so then he'd be able to leave when he has to, and I will then introduce the remainder of the panel. Neil Poe is the inaugural James Fry Distinguished Service Professor here in the School of Medicine and in the School of Public Health. He's the director of the Wells Center for Prevention, Epidemiology, and Clinical Research. I think perhaps more than anyone represents this blend of public health and medical research. So, Neil, let me turn it to you for observations, thoughts, and from there.
Okay. Well, thank you. Thank you, Ms. Washington. That was a wonderful historical portrait that was profound and an illuminating expose, I think, of the history of race and medical research in this country. And in fact, being here in Baltimore at Hopkins for 23 years, learned something about Baltimore and learned something about Johns Hopkins that I hadn't known before. So thank you for setting the record straight about many of the myths that we have heard about. One of the things I like to think about, and that has been a lot of the emphasis of my research, is thinking about how these myths then get translated and whether they affect the health disparities that we see today. The fact that we know that minorities in this country often get fewer of new treatments. You showed some of that research. They get undertreated for pain. And how do these myths translate into that? How also do they translate into the fact that minorities in many areas of medical and public health research are underrepresented in that research? Does it really lie in the fear of experimentation, whether that's fear of experimentation in the delivery of their care, or if they were to participate in a research study that they would be harmed? And Dr. Levis and I we've had some debates about kind of what really is the critical lesion that affects these disparities, and how much of the myths or real medical racism affects what we see played out in healthcare and in medical research today. So what do we do? How do we erase history? These images that you showed are indelible, actually, in my mind. Does it take electing an African American president to, as a visible sign to erase issues about inferiority of intelligence or ability to function in society? How do we restore trust among patients in the healthcare system, so that they actually are empowered to get the treatment that they so rightly deserve as all Americans? So I would love us to discuss some of those things. It's kind of, where do we go from here? What is the agenda to erase this history that you so vividly displayed? I'll leave it at that to start this off.
Thank you very much. We certainly will come back to those questions through the panel. Let me, if I may, introduce the rest of the panelists. Ms. Washington referred to Henrietta Lacks, and Ms. Lacks's son, Mr. David Lacks, is here with us today. Mr. Lacks was born in Baltimore, raised in Virginia, returned to Baltimore, and lives and has raised 3 children here. So welcome. I'll ask you to make whatever comments that you would like, but let me first also introduce the people to your left. Professor Tom Levis is the inaugural William and Nancy Richardson Professor of Health Policy. He is a professor here in the School of Public Health and Health Policy and Management, and is the director of the Center for Health Disparity Solutions, and one who has, as is true for the panelists, really dedicated his life to dealing with many of these issues. The final panelist is Professor Alan Green, who is in the School of Education. He is the chair of Counseling and Human Services Department in the school, and Alan is also Associate Director of the Urban Health Institute. So thank you very much all for coming. Maybe turn it to you, Mr. Lacks, and thoughts, comments that you might have.
Well, I have not too many thoughts and comments on anything. I'm glad Ms. Washington brought up everything she did, but I'm just glad that they have recognized my mother as far as being contributed to the medical field, and the knowledge that who she was, Henrietta Lacks, because they had her under different names at first. They had Helen Lane, Helen Larceny, but then now they got her, everything straightened out about that. That's the only thing I'm glad she's getting her just recognition. That's all I can say about that. Thank you.
Thank you. What some in the audience I know, but some in the audience I know do not know, is that in our community, your mother is legend. That I received probably 10 or 12 emails saying, I saw that David Lacks is going to be on the panel. Is that Henrietta's son? Or is that her offspring? Or so the power of who your mother was, her contributions, but also what she represents is very, very powerful. Let me turn it to Tom Levice.
Well, so I've heard Harriet talk about this about 3 times now, and have 2 copies of the book. And we first talked while she was writing the book, because I think when we first met. And so I'm very familiar with her work. And so there was one point that I wanted to sort of drive home that came out in the presentation, and it was the overburdened use of Tuskegee as a symbol of this mistrust, and the reason for the mistrust. And Neil alluded to it as well, Dr. Poe alluded to it, where CNN tried to create a controversy between 2 Hopkins professors fighting over Tuskegee, and it was Neil and I. We were like, what are you talking about? We didn't know we were fighting over Tuskegee. And but I guess it makes good television. I miss when Soledad was here, but anyway. What I guess my side of the debate, if there was one, was that we did a survey, the Health Disparities, Center for Health Disparity Solutions did a survey of the city of Baltimore. And we asked, it was a survey about trust of healthcare and what people thought about it. And what we found, and we were particularly interested in whether they were what was the source of the race disparities in trust, and what people would say in this survey. We asked people if they had ever heard of the Tuskegee, what's the new term for it, the new name for the study?
United States Public Health Service study of syphilis in the untreated Negro male.
That thing. And so we asked people, and we found that about 60%, 59% of the people surveyed had never heard of the study. And there was no race difference in who heard of it. About 60% of African Americans, 60% of whites said they never heard of it. And then we read them a description of the study, because maybe they didn't know it by that name, but they knew about the events. And about 60% had never heard of any such thing. But then we asked them, do you think something like this could happen today? 76% of the African Americans said yes, it could happen today. 57% of the whites said it could happen today. So the mistrust is there, absent of the knowledge of Tuskegee. We then went on to ask them about personal experiences of untrustworthy behavior in the healthcare system that they received or friends or family members received. We found that about 3 times more people had heard of Tuskegee than had personal experiences of mistrust, right? I mean, that they would make them mistrustful, which is a good thing, right, you would think. But when you looked at what was correlated with whether or not they trusted healthcare, we found that there was no relationship between knowledge of Tuskegee and mistrust of healthcare. But if you, your family member or friend had a negative experience in the healthcare system, this was very strongly correlated with mistrust of the healthcare system. So I think it's, I mean, and I know the presentation is focused, and Harriet's work is very much focused on the history and how that history informs what's happening today. But what I think needs to happen, in answer to Neil's question about how do we move forward, is that we move forward by engaging in trustworthy behavior contemporarily, now, We can't change what happened in Macon County, Alabama. We can't change any of these historical events, but we can change what happens now, and we can seek to further reduce the number of people who have those personal experiences or who have relatives or friends who have those personal experiences. And it's only until we affect that that we're going to affect the race differences in trust and therefore impact utilization and quality of care and outcomes that we see in the disparities data.
Well, thank you. I think that links with both what Harriet as well as others and Neil said. Before going to some of these issues, let me turn it to Alan Green.
Thanks, Bob. Like Tom, this is not my first time hearing Ms. Washington's excellent presentation. And as a person who's really more interested or equally interested in educational and mental health outcomes, particularly as it relates to research, I was struck by, in both this presentation and the one before, the sort of logic behind the thinking that went on in the past that suggested that, for example, resistance to slavery had some sort of scientific or medical basis, and how that thinking takes place today. So while we know that practitioners of medicine and other forms of social science and medical and social science research today do not necessarily think that black folks, for example, are subhuman, I wonder in what ways does the thinking of researchers impact the kind of research they do because of the same kinds of ignorance or bias or intolerance that took place then. And specifically in looking at academic underachievement, looking at prison, or crime, rates of crime or prison statistics, I'm just wondering how we can translate this argument that bias in research has taken place, which you've done such a great job of documenting, and how can it be expanded to other areas of research? Because I feel like, as I've been here at Hopkins now for 9 years, and I've seen how the community reacts to me when they see me separate from Hopkins in comparison to how they react to me when I'm affiliated with Hopkins as I conduct my research and do my work. And I know that there are a lot of myths out there related to Hopkins and its research, but there's also a lot of myths and mythology that you talk about within the institution, and I'm wondering how each of those can be put on the table at the same time in order to tackle these issues.
Let me, if I may, pick up with some of the questions that you're raising that tie in with some of the questions that I've received. And again, if you have questions you want to jot down on cards, there are folks who'll collect them, so just jot them down and pass them to the aisles. One says, researchers don't enter research to do harm. Their goal is to improve the lives of people. Yet there is an issue of trust and confidentiality that seems to be broken all too often. Do you, and I would use you plural, have concrete suggestions of things that we as researchers can do to bridge that? And I assume that ties in squarely with issues of increasing trustworthiness. What are the things that we who do research can do as we undertake our individual work? And then I'll also ask it about institutional levels.
I would just throw out there really quickly the idea of our acknowledging the pressures of doing research from within the institution. So the pressures of tenure and scholarship and grant making, and how that impacts our commitment to doing good. So when you're chasing the next grant or the next publication, that sometimes can pull away from your commitment to do good. So being aware of that and processing that on an ongoing and open basis, I think, is very important.
Neil?
Well, we did a research study, I guess it's been about 6 or 7 years ago, in the Baltimore metropolitan area. It was a random digit dial survey of individuals from the community, both African Americans and whites. And what was interesting, we found that there that African Americans had less trust in their physicians. They had less trust in the hospitals in the Baltimore metropolitan area. But they actually had more trust in the health plans that they belonged to. More trust than whites in the health plan. And while we weren't able to ask why, one of the things I think that we surmised was that, in fact, physicians in hospitals might have or be in a position to have more types of data that would be confidential than actually a health plan might have, and the potential to abuse that information. And I think that remains to be tested, but it was really an interesting finding that we have. You know, I think, thank God, we have human subjects regulations today. Although I think many think they're we've broken the system, we've overburdened researchers, and certainly it needs some streamlining while protecting the rights of human subjects. But I think we do have to restore trust, and I think Ms. Washington's solution of in fact, well, some of the solutions that she, I think, address this. One is the patient and subject education. I think that's vitally important to understand what research really is, and actually how researchers guard confidentiality of information that they collect about subjects. I think that can go a long way. I'll let Steve Tom wants to get at the microphone, so I'll yield to him.
Yeah, I just wanted to say, in response to the question about what researchers can do, I mean, I fully agree with the premise of the question. I think most researchers do not do what we do with the intent of doing harm. And when I served in the IRB, it was striking to me how many studies came across my desk that were from colleagues who I personally knew not to be people interested in doing harm, but that had harmful elements. And it's partly because of what Alan's saying about the pressure that's on you, and sometimes people lose sight of that. I think that the best way the best bulwark against that is to have engagement with the community that you're doing research with. That getting their input, not only on what are the important research questions, but for them to understand what the research process is about, why things are done the way they're done. I have found that I've gotten invaluable advice and information from community members who maybe aren't very well educated about research and research process, but once they are given some education about it, can be very helpful about finding ways to get the answers that you want without subverting the research process, but also while respecting the interests of the research participants.
One of the things that one of you noted, and something that in an earlier session we were discussing, and I'll just read it. The East Baltimore community and residents are very rarely informed about what really is found in the research. The feedback loop is rarely completed. And as a consequence, there's no sense that either I, or if it's not me, my neighbor might in fact be a beneficiary of that research. I think it is a real issue, and trust comes from information sharing, the good and the bad in information sharing. There are a few questions here that relate internationally. And since both this institution on the medical and public health side and nursing do quite a fair amount of international research, let me just touch on them. One is you speak about the exportation of exploitation. Two is, might you comment, and again, you plural, on racism in international research? Three, I believe that Africans are going through what African Americans have gone through in the past. Many Africans believe that HIV/AIDS was and continues to be injected into people. What do you believe about the possibility of Africans being injected with HIV? I would also ask, and what would you suggest as strategies for dealing with those beliefs if in fact it may not be founded?
I'd like to address that. I actually wrote an op-ed for the New York Times in which I addressed this belief of many Africans that some of the purported public health programs were actually strategies to inject them with infectious agents, including HIV. And again, this is a myth that we have to, as Westerners, treat with respect. It's very important to understand the factual, historical basis from it. In recent history, there have been several Western physicians who have been indicted and in some cases convicted and gone to jail for doing precisely this, injecting Africans with agents of harm. Wouter Bassan of South Africa was not convicted, but he had the longest trial, most expensive trial in South Africa, in which he was accused by all of his Confederates. All his fellow lab workers and subordinates all agreed that their project, Project Coast, was designed to do exactly that. So when you understand that doctors like Bassan, Swango, Richard, I'm blanking on his last name, these physicians were well known in Africa, then this belief that they may be injected with deadly agents does not sound so fantastic. So I think that context is important. Then too, let's look at actual transmission of AIDS, the etiology. We are completely silent about the documented transmission of HIV via unclean needles and vials. It's not done intentionally, I'm certain of that, but it does happen. According to WHO estimates, approximately 2% of the infections in 2003 came from dirty needles. And why would Western physicians use dirty needles? Because there's nothing else available. Very poor countries, very low budgets, limited sanitary. So again, I think it's another really important lesson in dealing with myths. No matter how we deal with it, we have to be respectful when we do it, or we're not going to be able to have the trust of people. So in terms of the exportation of exploitation, it's real. There are people in poor third world countries have always been abused by some medical researchers. It's always been the case from our perspective as Westerners. And some of it, you could call it abuse. In fact, I will call it abuse, but with a caveat, that some of it can't be helped. If you don't have access to a facility for cleaning needles, then you can't use clean needles. It's as simple as that. But the fact that this has been going on for a long time is one thing. I do believe that it has increased because we have changed some of the laws. The Declaration of Helsinki was updated a few years ago. And when I read most of accounts of the changes, they all sound positive. But as a bioethicist, I recognize changes that are not positive, in my opinion. Some of the changes actually water down the protections to poor people in developing countries. It used to be that if you were a researcher at Hopkins or another U.S. institution, you had to adhere to that institution's rules. You could not use something other than the standard of care. But now the law has been changed for developing countries so that instead of the standard of care, which in our country is an effective drug, you can use what is the standard of care in that country, which sometimes is nothing. So these kind of legal changes are a problem, I think. They're an abdication of our responsibility for medical ethics, and I just don't see how we can champion human rights and medical ethics here at home and abandon it abroad.
Others, anyone want to comment? Let me turn to another question. The focus of your presentation, reasonably, since that's what you were asked to do, is on race. Excuse me. But as one questioner notes, a lot of the disparities that we see, race is really a cover term for a lot of social inequalities and increasingly a function of income, social status, etc. To what extent are these iatrophobic, to use your term, issues relevant to those who are poor non-African American? Is it an issue of status and social disadvantage that we're really talking about today that cuts across color lines? And I'd be interested in the entire group's thoughts.
I think that's an excellent question. The answer is that we're talking about race mostly. Historically, this targeting, these vulnerabilities have been predicated not on socioeconomic level, not on education level, but on race, very nakedly. So through the vast majority of our country's history, we're talking about African Americans who were medically segregated, just as they were segregated in every other aspect of society. What happened in the medical arena only reflected what was happening in society at large. Physicians were no worse than anybody else. They simply were adhering to the mores of this country, which countenanced slavery, segregation. So we had medical slavery, we had medical segregation, and the targeting was specifically for black people. Not to say that some Europeans weren't harmed, of course they were. Certain white people who were very poor urbanites, especially if they were foreign-born, were also vulnerable. There's no question of that. And there have also been books written documenting their abuse. So that did happen, but what I've been discussing is racial targeting. Now, what's interesting is that today, of course, we do have nuances. We do have differences by socioeconomic level, and sometimes one is put at risk because of how much money one has. But one of the things I have noticed, and I'm still actually examining, is that even today, geography often puts one at risk. If you notice, if you go to many urban centers, including this one, the medical center is surrounded by a community of poor black people. This is not an accident. This is by design. If you look at history, if you look at the history of Richmond, Virginia, for example, and you look at the history of Cambridge and Boston and Massachusetts, in Boston, Harvard Medical School was originally in Cambridge with the rest of the university. The medical school was moved from Cambridge to Boston intentionally as a result of a petition by a Dr. Warren, who said we have to move the medical school to Boston. That's where the bodies of the poor people are. If we keep it in Cambridge, we'll never have enough cadavers, enough bodies to satisfy our needs. This is replayed across the country. And medical schools and hospitals located in the midst of these vulnerable populations. In Richmond, they specifically said, you know, we don't want to end up like Philadelphia, where they can't get any bodies for research. Why can't they get bodies for research? Because of the sole use of whites in the labor of the city. Richmond said they needed to locate their medical center in a black community so as to have access to those black bodies. So that's the other factor. There are socioeconomic factors, but there are also factors such as the intentional location of clinics and medical centers in black communities. And some of those still have an effect on who is put at risk today. So that having been said, because our country has changed over time, of course, you know, economic level education level, all these things come into play. And as I said, in terms of the erosion of consent, which I consider our biggest issue here, it is something that affects everybody. It's a risk for everybody. But black people are often still at disproportionate risk.
Before others comment, I do want to comment and point out, because I think particularly for this audience it is very important, and that is not why Johns Hopkins medical institutions are where they are. Johns Hopkins medical institutions are where they are by charter and gift from Johns Hopkins, and in that charter it was for service to, explicitly for service to, the disadvantaged of the community. So
yeah,
that,
and I think I mentioned it in my talk, Johns Hopkins was a law-abiding exception.
and I mention it because not because you don't know it, but others may not. A comment, Alan?
Yeah, I would, without arguing with your point about race and the importance of it both historically and contemporarily, you look at prison populations, or you look at, or even research that's driven by profit, I don't think that there is anyone who's exempt from exploitation. So I would just add that as a note.
And so I guess my point is a little more nuanced, I guess. I think that, I've said many times that poor whites and middle and upper middle class blacks are the two most understudied populations in America. We don't know a lot about those populations. In fact, at the Health Disparities Center, we recently did a data collection on low-income, urban, inner-city whites, and we're having a hard time finding a journal who will even publish on that population, who is actually doing very poorly. But the issue of Harriet's work, I think, is really about explaining how, in particular, this fear and mistrust of medical care and medical research evolved within African American culture. And I think that evolved out of a legacy that was very much around race. So while socioeconomic status is clearly an extremely important factor, and perhaps we can have a session or a series of sessions on socioeconomic status and mistrust or health outcomes, I think that what Harriet is talking about is something that evolved specifically out of race and specifically about African Americans in history in this country. And because of it, there's an aspect now in African American culture where distrust is part of the culture, and it evolved out of that history. So I think both are important.
Well, I have a stack of other questions. The bad news is we won't get to them. The good news is that we have a reception up in Finestone Hall on the second floor, right up there. And there, this is the second floor. So much for my directionality once again. Out that door. So there'll be opportunity to ask the questions that we didn't get to, and most importantly, to continue this very, very important conversation we have started. Ms. Washington, Mr. Lax, Professor Leviste, Professor Green, thank you so very much.